Good afternoon and good morning, everyone. My name is Linda Protopapis, and I'm the Executive Vice President of Sales for HealthRecon Connect. Thank you so much for joining our Part 3 series webinars. This one is going to be on RPP and GIP infectious disease. To walk you through these, it is our honor to introduce you to our Director of Laboratory Services and Support at HealthRecon, Mr. William Baus. A little bit about William before I hand this over to him. William has over 15 years experience in healthcare revenue cycle management. His last decade has been entirely focused on laboratory revenue cycle building onshore, offshore, and hybrid teams to satisfy the needs of the clients. William has worked inside laboratories as the Internal Revenue Director with preview over every step of the revenue cycle process, as well as managing RCM vendors. William is tirelessly focused on compliantly maximizing the revenue for laboratories, whether that is through the adoption of technology, application of deep state knowledge of payer and national coding policies, or providing access to relationships that can change the bottom line for labs. A few reminders to all of our attendees. If you'd like to ask a question, you may do so by sharing your questions via the chat box or raising your hands, upon which I will enable your audio video. Following the conclusion of the webinar, please take a few moments of your time to fill out a short survey. Let us know what you liked about this webinar, how we can improve, and what other topics would be interested in our future webinars. As a reminder, I will be sending out a personal email to everyone once the recording is ready, and I'll be sending that over to you to share with your colleagues. With that said, William, let's get the show on the road.
Thank you, Linda, and thank you everyone for joining. We'll be primarily focusing on respiratory pathogen and gastro pathogen panels today, perhaps even the UG-AG panels that are specified in the newer syndromic infectious disease LCDs, but I think we'll have plenty to talk about with this. So we're going to go over what a Medicare administrative contractor is, what the MolDX program is, who participates in MolDX. There's some interesting new things there. What a DEX code is. Do you even need a DEX code? Under RPP and GIP, we're going to take a look at MolDX Max versus non-MolDX Max for the Medicares. And then we're going to look at the impact of commercial payer policies on these panels. And I think I have something new and surprising, or that not a lot of people have been asking about, but it's something new that people are asking about. So stay tuned for Section 7. As always, the advice that we talk about in here is not advice for you in your specific situation. And so you wouldn't want to just take this information and run with it until you've vetted it by the appropriately qualified people. Sometimes I may make allusions to medical necessity. I'm only quoting what is available to us as the public. I am not a clinician or a medical doctor of any type. And so with respect to medical necessity, it's a two-part process. There's clinical side, and then there's what a payer thinks is medically necessary. And then even in that context, you have to be very careful. And I'm going to really reiterate that for the new thing I'm going to talk about today with relationship to respiratory pathogen panels. Okay, so what is a MAC and why do you care? Well, MAC stands for Medicare Administrative Contractor. These are private companies, privately held in many instances, not publicly traded. Some of them are publicly traded, that own the right to process claims for Medicare, and they get paid a lot of money for doing that. A laboratory will bill to the MAC where the lab is located, regardless of where the sample originated. So let's say your sample came from California, or your sample came from Florida, or your sample came from New York. The Medicare Administrative Contractor rules that will be applied will be based on the CLIA location of the lab that is doing the billing. Now, it's also interesting to note, right? I mean, almost every one of those states I mentioned, I think Florida stopped doing it, but you would need a license to receive run and process samples from California, as well as New York. And good luck getting that from New York. It can happen, but they will come out and do an inspection. And what they're looking at are the qualifications of the people for running your test and managing your lab and being your medical director, or being your technical advisor, these sorts of things. They have different qualifications in California than they do in Texas, for example. So if you want to take and run and receive and process samples from those states, you need to get licensed by them. So obviously, different Medicare administrative contractors have different rules. Not all of the Medicare administrative contractors participate in the MolDX program. We're going to take a look at that next. So before we do, let's talk about what is MolDX. So MolDX is the Molecular Diagnostic Program. They identify tests with a Z code, a DEX Z code. Do not confuse the concept of a DEX Z code with the concept of Z code, that being diagnostic codes that start with a Z code that are kind of generic diagnostic codes. If you actually do a Google and Google Z codes, you might actually be reading about stuff that's talking about diagnostic codes. So you need to kind of put in the DEX Z code to get to information about Z codes, the DEX Z codes, that is. What the molecular diagnostic program does is it's going to help determine coverage. So if you happen to be in a Medicare administrative contractor that participates in the MolDX program, they are letting the MolDX program determine coverage for certain tests. And we're going to take a look at exactly what tests those are. But as you can tell, it's anything that's in the molecular diagnostic arena. Now, of course, infectious disease actually lives in the CPT code book in the microbiology section, because you are not studying the human body, but rather the pathogens inside the body. So the concept of molecular diagnostics is not aligned with, well, what CPT would say or what a clinician might think of the kind of testing that you're doing in the traditional ways that we do it. But you are using technology that looks at DNA and RNA. So the complexity of that testing is at that level that it falls into this program. And we'll talk about that a little bit more. It also determines reimbursement. Now, your Z code is not a payment code. It does not replace the CPT code. It is added to it. And we're going to look at a little bit about what the details of that thing is. But basically, it's describing to a payer exactly what you're doing, which CPT codes don't do. So think of it as the MSG to your salt on top of whatever you're eating to make it taste better, right? They're going to know a lot more flavor about your test that way. The only real benefit that it has, though, is it kind of reduces documentation review requirements. We went over that last week a little bit in the context of PGX, for example, and a non-MolDX MAC, such as First Coast or Novitas, for example. You have additional requirements to getting that claim paid, called you need certain specific diagnostic codes, but in a MolDX MAC, you don't. So you kind of see things kind of align like that, that if you actually do get your Z code and your technical assessment approved and you get your recommended MolDX code, you get a lot less hassle on getting your claims paid. So it kind of clears the path for a little bit more certainty in your payment, a little less, hey, let me check up on you stuff, because we did a lot of checking up front before then. And so it's a little bit easier once you've gotten that process nailed down. So I think another interesting thing to note is, McKesson in 2011 started the whole thing. And if you kind of read through what they talk about and what their purpose for doing this was, is they were inviting labs to participate and payers to participate. And it was supposed to be a little bit more like we were all going to have a conversation about this together. And now it's morphed into what it is now, which is a really good way for a payer to put roadblocks into you developing new tests. And so this is kind of, I think, the general attitude of it from a laboratory's perspective. From the MolDX perspective, though, what they're trying to say is, look, the CPT codes don't tell me enough to know about what I'm paying you for and if I should be paying you and if it's medically necessary or not. So there is an argument, but it does really seem like there isn't much of an option for us to do anything but obey. And there's not really a good dialogue going on right now, particularly in the context of infectious disease. So it was subsequently purchased by Palmetto GBA. I was doing a little research a couple weeks ago and realized the reason that Blue Cross Blue Shield of South Carolina uses the MolDX program is because they own Celerion, which owns Palmetto, and they also own CGS. So there's a lot of alignment here with ownership models in terms of who's using the Z-code program. I think that would help people kind of understand the context. Is Novitas going to adopt the Z-code? Is First Coast going to adopt the Z-code? Is National Government Services going to do that? And I think when you start looking at how the ownership of these different entities are in alignment, like Novitas and First Coast and Blue Cross Blue Shield of Florida have the same kind of parent company scenario as well. I would think it would be unlikely that they would choose to basically say, look, I don't know how to handle molecular diagnostics, and I need you to come in and figure out how to get it paid for me. The anomaly is that Noridian did that, and they are not owned by these guys. So there's probably deeper levels of what's going on there than anybody will know without a lot of research. So the next thing is, okay, who participates in MolDX? And so that's Noridian here. They have two separate jurisdictions. And when they were awarded this red jurisdiction, Palmetto was very vocal about challenging that award, but they were not successful in gaining it for themselves. But Noridian here is participating in the MolDX program. So is WPS over here in the yellow and also in the green. And then, of course, CGS, it's just Ohio and Kentucky here. And then, of course, the two jurisdictions of Palmetto. So then the ones who do not participate in the MolDX program would be Texas and basically the contiguous states, plus Colorado and Mississippi. And then don't forget over here, you've got Pennsylvania and New Jersey, Delaware, Maryland, you've got all of these little states bundled up right here that are not participating as well because they are Novitas. And it's just because they're separated by geography doesn't mean that they are processed differently. They're just processed under the Novitas rules. And then, of course, you've got First Coast, which is Florida and Puerto Rico and the Virgin Islands. So I think another thing to be aware of is, of course, Blue Cross Blue Shield commercially is participating. Medical Mutual of Ohio and Fallon Health are, which I actually believe are owned by that Celerion company that's owned by Blue Cross Blue Shield of South Carolina, which would fall right in alignment with ownership. And then now we have the Medicare Advantage plans adopting this concept. I can kind of go into this if we've got more time later. I think there's something important to note that it does appear that we are getting denials now for not utilizing a Z code for Medicare Advantage plans in non-MolDX MACs. Originally, it was stated that they wouldn't be doing that. But then they came back later in April and said that they would do that. See, like originally they said on October 1st in Medicare jurisdictions that have implemented MolDX programs. And then later they came back in April, which is not that one. Where is that? Let me see. And later they came back on April of 2022 here. Let's see if I can make that a little bit bigger. And said that the requirement to use Z codes was expanded to include all states. And that for the Medicare Advantage programs is not in the same alignment for the required diagnostic codes when you are in a MolDX MAC. So right now it's really only the codes that start with 8.1. So it doesn't include the codes we use for infectious disease, which start with 8.7, but that will get rolled out at some point when it's not been released yet. But I can tell you this, for example, pharmacogenomics, I have been getting denials in non-MolDX states because they need a Z code. So that's already happening. You might want to consider looking at getting some support on your Z codes. So what is a Z code? It's a 5-character alphanumeric code identifier for a laboratory test. is unique to the laboratory and the particular test. So you will get a Z code for every panel that you do, that you want to bill as a panel. This basically means you're going to get one CPT code. So if you don't have a CPT code that recognizes your entire test, they're going to give you like an 87999, which is not otherwise classified code, which does not have a fee schedule, and it's very difficult to get paid for that. But you would definitely have the potential to get, an 87631 or 32 or 33, and we'll talk about those, or the GIP codes, because you have the bundled codes, one code representing the entire test, and get a Z code that would go with that. And you wouldn't have to worry about the gap fill because they're going to use the price that code is listed at on the clinical laboratory fee schedule. And yeah, it's not a replacement for a CPT code. So do you need a Z code? If you're doing two or more pathogens and your test is not FDA approved, then yeah, you need to get a Z code. And even if you were using an FDA approved test, it has to be a single test, not a bunch of tests kind of stacked up together. Again, one code. So the decision tree kind of goes like this. Is your test FDA approved? If the answer to that is no, you need a Z code. If your test is FDA approved, yes, well, and you're using a diagnostic code and CPT consistent with the billing and coding article, well, then you don't need a Z code. But if you're not, you still need a Z code. So you need a Z code in most instances. Although the two tests we're talking about today, there are FDA approved versions of these tests, and you could be using those tests. And as long as you're following the billing and coding article, you don't need a Z code. I will come back to this if we have time and there are questions related to it. These are the 3 steps to getting a Z code. And first, you're going to register. It's a little bit light there. I hope you can see that. You need to register your organization, which is, what's the name of my company and my tax ID and my CLIA number and who's going to have access to the system and blah, blah, blah. Then you add your tests in. And if we have time, I'll kind of pull up that spreadsheet and show you all the steps that you go through to answer to put together your request for a Z code. And then, usually within 2 weeks, they're going to send it back to you, assuming you haven't made any glaringly obvious mistakes. Sure, here's your Z code. And here's your the CPT codes you asked for. And so a lot of people assume, oh, that's great, I'm ready to go. But no, you're not. You're not ready to go until you successfully get an approved technical assessment. And you're actually required to turn that in with about 15 days after you get your Z code. So I would be working on that at the same time I'm doing my Z code. But you're not ready to bill until that thing comes back approved. If you continue to bill during that time frame, MolDX has made it clear that you are out of compliance with an LCD. They didn't go so far as to say exactly what the time frame is for recoupments and clawbacks and what actions they would take, but that usually means clawbacks, and it could mean that they stop paying you for a little bit while they figure stuff out, which could be potentially devastating if you are heavily reliant on Medicare income. All right, so let's start looking at the specifics of a non-MolDX respiratory pathogen panel in Novitas, First Coast, and in National Government Services. Their LCDs are very, very much in alignment. Their Novitas and First Coast are verbatim and lockstep in when they drop. NGS is kind of its own deal. They drop at different times. There might be variations in required diagnostic codes, but the content and the intent is basically the same. They're not going to pay you for the bigger panels, period. So whereas in a MolDX MAC, they will, under certain additional requirements, they haven't worked that in yet. Yeah, they could possibly go back and rework that and create a syndromic panel LCD minus the Z code requirement, and it would look pretty much like a MolDX MAC. But at the moment, that's not the way it is, and there is no currently scheduled future proposed LCD to show those changes at the moment. The time frame for something like that would be that they could show up with a proposed LCD. They usually give it a month or two, and then they have it open for comment period for about 45 days after that. And then they could implement within as early as 45 days from that. So I think we're at least 6 months away or much longer, if they never make a change, that a change could be implemented. They do pay for 87631, which is your 3 to 5 targets. And then they'll pay for the 87636 and 87637, all of which come in at $142.63. I think another important thing to note is the LCDs for Novitas, First Coast, and NGS are very specific in that they're talking about these codes being viral target codes. So there's a lot of work and understanding to deal with your bacterial targets, and you should definitely talk to a knowledgeable billing company to explain to you what, in the absence of documented clinical medical necessity and utility in an LCD, you're going to default towards medical necessity as dictated by a ordering physician. But I think you should always take a very deep look that if you're ordering everything on everybody every time, you will not have medical necessity for all of them. And that would become very apparent in your billing pattern and in your ordering pattern. So it's highly recommend that you really rethink your RPP panels. If you're also including bacterial targets, there should be additional medical necessity, which in the absence of that being documented by the payer, you're going to want to rely on clinicians to help you define that. Now, there's a new thing. This is the little special thing. And I highly recommend that you don't go off and start billing this code or promoting it with doctors without really looking into the medical necessity for this. It's code 87913. It's genotype analysis or mutation identification in targeted regions. Now, I have spoken with labs in the past that had developed PCR methodologies that were basically looking for every possible permutation or variant of the COVID virus. This would not be an appropriate utilization of this code. This code is certainly not covered by national government services, number one. It's only for First Coast and Novitas that it's been written into their LCD that it is covered. It utilizes the same diagnostic codes that cover you for an RPP test, but don't let that fool you because they just didn't bother to kind of separate it out and really narrow it into a few specific diagnostic codes. But number one, you're only utilizing this test after you've already identified the patient has COVID, according to the AMA. And so you don't want to see a patient who was positive for COVID. And then you would definitely need the result of this test to be utilized in guiding the change in treatment for the patient. And I'd really like to hone in on that point for just a second. It seems like, every day there's new tests available in the molecular arena. And there are several levels to the concept of what they're doing in a technical assessment from a MolDX perspective, which, while we're not talking about a MolDX MAC, it's important to understand that all MACs think about it like this. There's analytical validity that your machine can actually get the right result and reproduce that result and compare that to another person who got the same result, and that your machine does what it says it's doing. Usually that's not what they're talking about, that they're going to have a problem with. And then there's also clinical validity, which is that you're doing your specimen testing and your positives and your negatives, and it's also kind of tied into the validation. But the most important one is the clinical utility. And this is where clinical utility does not always match up with practicing doctors' version of medical necessity. Whereas a practicing physician, they may want more information so that they can better guide the treatment of their patient, which is fantastic. And we want to provide them that. But then there's also a limitation from a payer side that, well, you might not need to know all of that information given a certain level of a problem with a patient. And this is what the clinical utility section comes in and looks at and says, sure, you might be able to find out this information, but if there's no appreciable change in the treatment of patient for knowing this information from their perspective, which is not the doctor's perspective, well, then they don't want to pay for it. And you don't have medical necessity in their version of what medical necessity is. And so that's always going to be a level of contention. And you're typically going to run into that a lot heavier, as we talked about in our first session when we talked about infectious disease for nail, wound, and UTI. And that's the problem that you have, is this new technology doesn't have specific codes for it and doesn't have all of the clinical trials that have been performed, and then that documentation of those trials having been reviewed in peer-reviewed literature, and then having been accepted in mainstream, and then also not having been contradicted by other peer-reviewed literature. Once you've gone all the way through that, you probably have a code. This is why we have code for RPP and GIP at different levels, and it's well accepted. And you have very defined and specific expected diagnostic codes, right? When you're off the map and you don't have these things, you're pushing for what's new and may not be well accepted by a payer for payment, as we did kind of mention in one of our previous talks. And so in the context of this, what the AMA basically said is, well, you need to be positive for COVID. You must be used to guide treatment. And what they were alluding to in that would be, somehow this helps you distinguish between a persistent infection versus a reinfection. And again, this is the AMA, which doesn't necessarily mean Medicare is going to believe it the same way or think of it the same way, but it is listed for Novitas and First Coast. And there are diagnostic codes that kind of talk about, in the second one a little bit more, evaluate the efficacy of antiviral medications or antibody treatments, perhaps, right? Knowing what variant you had might help you select a better monoclonal antibody infusion, perhaps. But you'd really better have that straight, and that better be 100% right, because that code's $250. And if you just start saying, well, hey, I test for 10 different variants, not this code, no. Even if you had the genetic algorithm that you figured out that, oh, I could test for every possible permutation of the variations in COVID, and this is the test I want to run the first time on somebody. No, at least not according to the AMA. So again, this would be one of those things you definitely want to talk to your biller. You definitely want to talk to your clinicians, and you definitely want to have it locked down that there is clinical utility for this test, and it is guiding real changes in treatment for the patient. And you're going to want to have that back up in your pocket. If you did, then this might be something for you to look at. Okay. The MolDX RPP, pretty straightforward. You need a Z code for anything more, 2 or more pathogens. I can't say that enough. It seems that there's a lot of confusion about this, but yeah, you need a Z code for everything that's in that billing and coding article. You don't need a Z code if you run a single gene test, which they even say in the article they don't think is medically necessary, which is funny because that kind of contradicts itself for COVID testing, for example, or for monkeypox testing, especially when they don't want to pay me for like 10 different STI tests when I'm doing a monkeypox test, right? So they have their cake and they get to eat it too, and they self-contradict themselves, and it is very frustrating. But if you want to get paid and not have problems, follow what they tell you to do. And so what that means in a MolDX MAC, whether that be Palmetto, Noridian, WPS, or CGS, is if you've only got one diagnostic code with coming from the symptomatic diagnostic code group, which is actually code group 1, then you're going to be billing an 87631, which is the $142.63. So there is a potential to boost that slightly, but it's really only appropriate in the context of speaking about a particular panel. Do give us a call. We could talk about that in some detail in specific relationship to your panels. I think the other thing to notice is it was clearly stated in all of the MolDX LCDs. I'm going to paraphrase it a little bit, but hey, look, we understand you as labs that you orientate your instrumentation such that you may be testing a bigger panel than what you have medical necessity for. And in such instances, we will be quite happy to pay you for what you have medical necessity for, AKA $142.63, not $416.78, right? That's what they're telling you. And that flies in the face of, the typical way to look at this is what is ordered must be what is resulted, must be what is billed, or you have the potential for having created an inducement scenario. And so there's a bit of a contradiction there in the actual LCD, but that is what it says. But before you go off and implement anything again, you do need to talk to your lawyers. You do need to talk to your billers. And if you're in network, we would be talking to your payers as well. Although I guess we don't need to worry about Medicare right now. If you're going to try to do anything 6 or more pathogens, that's going to be the 87632 or the 87633. You're going to need not only a diagnostic code from code group 1, you're going to need an additional diagnostic code from code group 2, which is an immunocompromised diagnostic code. So that means so transplants, because you're killing your immune system or turning it off when you do that. People that have HIV, people that have genetic disorders, immunodeficiency problems, right? And there's also the requirement that for RPP, you have a pulmonologist ordering it or an infectious disease specialist, unless you're in a geographic region where the next closest doctor is not one of those, and that's the one they're going to see. And then there were also some places of service which made no sense at all, because they basically said that this LCD does not cover hospital inpatient stuff, and the places of service they talk about are in inpatient places of service. So it doesn't make any sense that they bothered to put that in there. All right, so that's MolDX RPP. Okay, commercials, and what are they doing? They're all over the place. Cigna, Humana, most of the blues, solid payment on 87631s. I do see some reimbursement for a 3.2 or a 3.6. It's probably some ERISA plans. It's hard to delineate. And this is a thing I think, garbage in, garbage out. If all the data that you can give your billing company is it's Blue Cross Blue Shield, but you're not saying it's like an HMO plan or it's an ERISA plan, and you don't get the actual plan name and stuff, it's really hard to delineate exactly what's going on. But in my experience, when you are getting paid for these higher level codes, it's probably an ERISA plan that is not using Blue Cross Blue Shield to actually apply all of their adjudication techniques, and they're just kind of paying you 50% of whatever you bill, which happens on a very small portion of claims. UHC doesn't actually have a policy on their commercial plans that I can identify. If somebody else does, let me know. I'd like to know where I'm not looking in the right place. But they have them for their Medicare Advantage plans, and they talk about it from Medicare. They will reference you to other documents that they have that really don't give a good indication of what their commercial policy is. But their policy for Medicare Advantage is exactly whatever MolDX policy is. And when I do look at the data, it's predominantly 87631s being paid for, 3.2s and 3.6s sometimes. Actually, 3.3s I meant. That should say 87633. Excuse me, that's a typo. And let's see, Aetna is very similar to that. It looks like they're paying for some of the bigger ones. It looks like they're kind of looking at the immunocompromised concept. But predominantly it's 87631. And then of course, there is much to be said about the specific bacterial targets and that kind of rationale, as those are individual codes, we covered those in the previous talk we had, and with all the attendant rules that they were. And in summary, that basically is, it's down to the individual pathogen. They don't pay for certain codes like 87798, like Cigna doesn't even pay for it at all. So you're not really going to get a lot of hits on your bacterial targets when you're doing an RPP as well. So there's that. But you do get higher allowables than what you get from Medicare when you're out of network. But then it does go to patient responsibility. So it's a problem. All right. Now, non-MolDX gastro panels for Novitas and First Coast. And it's different for NGS. It's kind of like the flip of what this is. So it was a recent update. I think it was a couple of weeks ago for Novitas and First Coast. They dropped at the same time. They're verbatim in their wording and their diagnostic code requirements. And so up until recently, you could have got paid for the 12 to 25 targets with only one diagnostic code, R19.7, which is unspecified diarrhea. And that is like literally the only code that covers these tests, or up until recently, the only code that covered the tests. Well, now what they've done is they've said, well, we'll pay for the 3 to 5 or the 6 to 11, which is it's $128 for the 3 to 5, and it's like $262 for the 6 to 11. They will still pay for either of those if you have unspecified diarrhea for greater than 7 days. And they will still pay for the top tier code, but you need the R19.7. And then guess what? Kind of a lot like the MolDX Max, they're going to ask you for an immunocompromised diagnostic code. And some of them even overlap with the same diagnostic codes you see in a MolDX Mac, but there's some of them are different, right? So yay us, more different diagnostic codes to deal with. But you still got a sure bet on 262 with diarrhea. Now, NGS is kind of the flip of that. They will pay with R19.7 or A09, which is like colitis or, inflammation of the bowel. And they're going to pay you for the 3 to 5 targets, which is going to be the $128. If you want to get paid for anything of 6 or more pathogens, well, you need one of these R19.7 or A09, and you need one of those immunocompromised diagnostic codes. And there is a lot of overlap on what they are between those two MACs, but there's also variation. So even more to deal with. And then finally, on a MolDX GIP, you're going to have 5 or less pathogens. You need just the one diagnostic code, which is not the ones from the other MACs, but there's a whole list of them in there in that syndromic panel. And then they'll pay you for that one, 3 to 5 pathogen target. If you want to get paid for more, it's the same kind of thing with RPP. You're going to need one symptomatic diagnostic code, and you're going to need one immunocompromised diagnostic code from group 7. And then you can get paid, up to $416.78. But you also need a specialist ordering it, which, they tell you it could be a gastro, right? Or an infectious disease specialist. And then I think there's even oncologists that are able to order this kind of stuff too. And then they did the same place of service thing that didn't make any sense. But that's what you need to get the higher code paid. And yes, of course, you needed a Z code for all of these panels, right? Even the 3 to 5 target panel. All right. So commercially, it's some kind of variation of what we just went through. They either only pay for the first one, like Cigna only pays for the 3 to 5 targets. They don't even give you an option, at least in their payer policy, that they will pay for that. Now, you will see at times people actually billing that higher code and sometimes getting paid. And again, I believe it's somebody that's using Cigna as a third-party administrator, and Cigna isn't really doing their full thing, and they're just paying like half of whatever you bill. So you do see some payments. Just make sure that when you're getting a denial that you are working with a good billing company, because here's the difference between a laboratory focused billing company and a non-laboratory focused billing company. I was literally on a call the other day with a laboratory that is using a non-focused laboratory billing entity. And so their attitude with this was they billed an 87507 to Cigna. And Cigna sent back a request for documentation, which I don't even know why they did this. This just shows how jerks they are, because they know you don't have any documentation that's ever going to support the payment, but they still say, hey, you try to bill that code, fine. Why don't you send me some medical documentation that they already know is never going to be good enough? So then there's this scramble by that billing company to get that lab to go back to the referring provider and ask for diagnostic codes that are immunocompromised, right? And then they couldn't get them. So their next step was, well, they were going to uphold the denial as, well, it's not medically necessary because you ran a 12 to 25 pathogen panel. But with Cigna, if they tell you they're not going to pay for those two codes, you would definitely bill it with 87505 from the get-go. And that's what the difference is when you're working with a HealthRecon versus a not HealthRecon or any lab billing entity that doesn't know their lab billing codes, right? So you really got to ask your billing company, are you billing for other labs? Are you billing my panels, and are you billing my panels in my region under my Medicare administrative contractor? And are you billing Cigna? And are you billing my Blue Cross? And are you billing Aetna and Humana and United or not, right? If they're not, they can actually misinterpret a denial and assume that it is appropriately not medically necessary and write that off when you could have still made your $128. All right. Blue Cross Blue Shield of Texas is just like NGS in terms of they say that they will pay for the low paying code, but then if you give them, the immunocompromised, they'll pay for the bigger one. United, 87505 with, a symptomatic reason, no problem. They will pay for the second tier code when you have, the symptomatic diagnostic code and an immunocompromised diagnostic code, although they're not really specific about what the immunocompromised diagnostic codes are. Aetna, the same. They will pay for the 5 and the 6 with, the symptomatic diagnostic code, but then they're going to ask you for the immunocompromised diagnostic codes for the top tier one. And then Humana is okay with 87505. And then you need the 6 and the 7 with an immunocompromised diagnostic code. So the thing that's really repeating here is you need your billing company to pay attention. Do you have the right diagnostic code to build the right level of code that you have the medical necessity for? And so that concludes that portion of it. And I could go back and talk about the steps to go through a Z code, but I thought I would stop here and see if we had any questions on what we've already been through.
Does anyone have any questions for William regarding what he has gone through so far? Do you want to just write it in the chat or the Q&A, and then I could, put you live with William? I don't see any yet, William. So if there's anything else you want to go over, please do so.
Okay, sure. So I thought I could briefly run through what the steps are to get a Z code. And the first step would be to register your organization. And you do that by going to the app.dexzcode.com. And you can even register as a public user. And this would allow you to, you won't be able to see the Z codes of another lab. Those are considered actually private. But you would be able to see that they do or they don't have a Z code and that it is or it isn't covered. So like, for example, let's say you were going to buy some tests from Fulgent. And let's say you're in a MolDX MAC. And if the test that you're going to buy from them doesn't have a covered Z code, then it's unlikely that you would get paid for that. You have to use their Z code. even if it is a covered Z code, that test, you'd still have to kind of check with your MAC to make sure that they will pay for it in your MAC, because different MACs might have a different viewpoint on paying for that test, actually, especially if it's like an unlisted code, like an 81479, which would happen on any test that you did that had multiple. Normally, the way you would bill it would be multiple CPT codes. They're going to give you only one code, and then they come up with a price for that. And it should be expected that any other MolDX MAC would honor that price, but that was priced by that individual MAC. And so the other MAC might have a different price, and they do have variation in pricing. For example, the clinical laboratory fee schedule works this way. Once a code is in that clinical laboratory fee schedule, the fee is the same for that CPT code across all MACs. When you are experiencing differences in payment, it is not because for a CPT code, that dollar amount is less than someone else's CPT code. The difference is that you are not getting paid at all for one or more of the CPT codes that you are billing, right? But when they come up with pricing for things that are not in the clinical laboratory fee schedule, like an 81479, it does get specific to the laboratory, and certain codes, before they are adopted into the CLIFs, the clinical laboratory fee schedule, such as monkeypox, for example, which is paid at $35.09 in Noridian, but $51 and so many cents in Novitas, until that code is actually adopted by the clinical laboratory fee schedule, you can see variation in pricing. But once the CPT code's in there, then it's always the same. So anyways, registering as public user would allow you to look up tests to see if you were going to try to buy a test from somebody. I would look to see that, do they have a Z code for their test? And if they have a Z code for the test, it'll tell you whether it's covered or not. It won't tell you the price, and it won't, well, sometimes they write in the price, but it won't tell you what the actual Z code is. And sometimes there is a price and sometimes there isn't. And I think that's just a matter of how the lab writes it in or not. And all you do is you go in and register your lab by, you give them your CLIA, your tax ID, your, I can show you a little bit about what that looks like. So it's what laboratory type, your organization number, your address, you're putting in contact information. You have to sign off on some consent about that this information that you're giving them, they are going to share that, so that people can find you and look you up and find your Z code, right? And then you could register as just a public user, so you could start looking up labs and things like that. So once you're registered, that takes like 5 to 7 business days. Well, then you can go in and start adding tests. And so when you add a test, these are the steps that you end up going through to do that, right? So you give a test ID. It's supposed to match your requisition. That's one of the things that you're supposed to send to them. Your test title, whether or not you're the performing lab. And if you're not the performing lab, then you don't need to do a Z code. That's kind of an important thing, right? The Z code is specific to your lab and to your test. And so if you're not running the test, then you need to use the Z code of whoever ran that test when you bill, if you need a Z code, which you will if you're in a MolDX state. And you would also need for Medicare Advantage for certain codes. Right now in the 81,000 series, which would be like PGX. Is this test intended for a Medicare beneficiary? Yes or no? You give a description of your test, and you're putting in the information related to, the items that you're seeing here in your test description. So it's like the list of your pathogens. If you're doing syndromic, it's a list of genes. If you're doing PGX, that sort of thing. The molecular component, the variants of it, the mutation types. If your test was FDA approved, and you also, this is the other thing that's funny, because the syndromic LCD says, hey, if you're FDA approved, you don't need a Z code. But then if you go and read the Palmetto website, and the way it's always worked in the past is, yeah, you still get a Z code even if you're FDA approved, although you're going to sail right through your whole technical assessment process. And that's what they're asking you this for at the level of the Z code is, well, what's your 510K and your FDA document numbers and device kit, manufacturer, all that stuff is your FDA stuff. And then you've got your test type, diseases and disorders, methodology, and these are drop downs that you end up selecting. So, did you do it on real-time PCR, or did you do it on, primer PCR? All the different kinds of PCR are in there, right? And all the different kinds of NGS testing are in there. So you're picking the methodology, right? And then the medical specialties, again, it's a drop-down list. Who's going to be ordering that test? And then again, they ask you about your FDA stuff. I don't know why, but they've already asked it again. And then what you do, and this is the one spot where your billing company can really help you out with, because all that other stuff you should know because you're the lab making that test, right? But the one thing you should be asking your billing company to help you out with on a Z code is, well, what are the codes we would want to use to bill for it? Now, this is important because those CPT codes are the codes that, that's what we would normally bill. But remember, the way MolDX works is if you're talking about multiple codes, they're just going to mush them all together into, in the context of infectious disease, an 87999. In the context of a molecular pathology, it would be an 81479, and they mush them all together. But you're putting in those codes to say, hey, this is kind of what I expect to get paid. And that is taken into consideration when you do the gap fill. And then you can put in your price. Anything that says it's optional or it doesn't require you to do it, you're going to have to do when you do your technical assessment. So I would just go right through this Z code as fast as you could so you can get to getting your technical assessment done and enter what is required, right? If your test contains an algorithm, the UGAG panel 81514, for example, the BVAB panel for women's health, which is a collection of, like Gardnerella vaginalis, and then Trichomonas vaginitis and Lactobacillus. I'm brutalizing the names of these bacteria, but, it's not just you doing the individual pathogens. You also have an algorithm that quantitatively looks at the levels of those pathogens that are found and then produces we wouldn't call it a diagnosis because the doctor is the only one who can diagnose a patient with somebody, but it's going to say, yeah, that looks like vaginitis. And then the doctor is going to review that result and then make the diagnosis, right? Which is a very different test. It's a multi-analyte algorithmic analysis test, an MAAA test, versus the individual pathogen codes that we use. You could basically effectively be running that test by comprising all the individual pathogens and then identifying that, yep, it's there, or no, it's not there, which is not the same thing as this UGAG panel that's in there listed. You need an algorithm and you're actually quantitating the detected pathogens. Comparable tests or assays, that's usually a good thing. Like if you were trying to do a UTI and you already knew somebody had a Z code already for it, you'd say, hey, I'm doing the same thing they're doing. Specimen information, handling instructions, estimated turnaround time. The clinical validity section is optional here. That becomes a big component of your technical assessment, and you'd want to make sure you had that. That'll be where you get stopped, particularly on anything that's not in the LCD right now, like the UTI, nail, and wound type stuff. Precision, analytical sensitivity, specificity, all of these are all optional. I would wait until I had to deal with them in the context of my technical assessment. And then lastly, you submit for your technical assessment. And we've got a few minutes left, so I can do some of that. Let's see. Okay, I agree. So you would go to your forms thing. And the first thing you're going to do is you're going to pull up your technical assessment submission checklist. And that's going to guide you through. By the answers to these yeses or nos, they're going to tell you what technical assessment form you want to do. Like, oh, yes, I'm doing PGX. Well, then you need this technical assessment form, which is right here. It says pharmacogenomics. And then if you were doing a syndromic infectious disease panel, it would be this one. And we can take a look at that. Where is it? Why does it keep bringing me back to that? Let's try it one more time. So you have your test information, and this is pretty straightforward. The kind of people who can do this are the people who set up and validated your machines, your medical director. If you're kind of using a remote one, it would be beneficial for them to help you kind of look at filling this out, or use the company that helped you set up your validations. Then you have your analytical validity and clinical validity summary. And, the things that I see people having trouble with are they didn't do linear regressions, and they don't have this information done by unique samples, by the actual organism and targets, or the individual organisms, or at the sample level data, they don't have enough samples of the positive and the negative on each side of that. And also, they keep changing these forms. So you want to make sure you always go and download the most recent one, because it really sucks to go through and do all this data. And then they've added another column in or something like that. And they continually are doing that, right? So it's best not to download one and then 3 weeks later start working on it. I would go download it again and make sure I was working on the most current one. This is the section where most people are going to fall out. The clinical utility section, that's the reason why people can't get their technical assessment passed for, the UTI or the nail or the wound or the ophthalmology or whatever it is, because there haven't been any clinical trials utilizing this technology with that exact sample collection methodology that shows these clinical outcomes, right? And they've added a new tab since a couple of weeks ago called a change log. Okay, they're adding their change log. Okay. All right. Yeah, see, 11.2, they just added all that stuff. Okay. Interesting. So that concludes the presentation, unless there are any questions.
Does anyone have any questions for William? I don't see any questions, William.
Okay. All right. Excellent.
With that, with no questions, that will conclude today. And thank you so very much for joining. Again, I will have a copy of the webinar in an email format sent to you sometime this week or early next week. Thank you so very much, and enjoy your day. Thanks, William.
Bye.